Some of the machines have a renal setting. Let's go ahead and start here. Start. Say what's going on there, everybody. Okay, that's a new one. Also, wipes and paper and gloves have been ordered. I don't know when they're coming. I brought in from COVID, I had 2 containers of wipes. So there are a couple more containers of wipes, but you may end up having to share a little bit until we get the supplies in. Okay. So when we annotate this, well, let's start from the very beginning. So we're gonna do what we would do for a normal renal ultrasound. So, oops, let's get our 2D out. So we would do our SAG IVC, looking for any tumor invasion. We would do our prox aorta, mid aorta, distal aorta. We're going to do our urinary bladder, go ahead and breathe, urinary bladder with and without jets. And then we would do our native kidneys. So we would just take a sagittal image, look for pathology, do our sagittal image right, sagittal image left. And then we're going to look for our transplant. Again, typically these are going to live in the left just because there's more room, but they could also live in the right or kind of more central. I'm going to have to roll just slightly away from you, just so you're still seeing. Okay. So we annotate this. We're going to say transplant kidney, transplant renal, and we're going to give an idea of where it is. So we'll say right lower quadrant. Just give them an idea. Oop, can't get out of there. What are you doing? What are you doing? And then we're going to do our SAG, medial, lateral, things like that. Go ahead and get it. Nice gallbladder. Look at that thing. Oh, man. And so we would get our regular sagittal image, the same that we would do for normal kidney. So SAG, medial is always going to be closer to where that vasculature is, so the lymphatics, ureter vessels entering in. Lateral is always going to be opposites to that. So depending on where your go ahead and breathe, where your patient's kidney is, medial, lateral. So those ones are the easy ones. And like Masha brought up, if we have one that's totally horizontal in here, we just have to pick a side. So I might say superior / lateral right. So like, hey, I called the superior the lateral right aspect. So we might have to kind of make up our own superior and inferior. But for the most part, they're going to be in there slightly angled, so you will have more of a true superior and inferior. Okay, so we'll do our SAG image and then quite a big breath in. Then we're going to show one image just showing perfusion. So that's going to be with our Doppler color. And we could, again, choose to use power Doppler. And hers, come on, trackball. And hers is, go ahead and breathe. Hers is showing up fairly well. So I could probably angle a little bit better and get more perfusion in that superior just to really prove that there's some perfusion there. We're seeing nice perfusion in the mid and the inferior. So this would be kind of our one image that we would start with as far as just showing, after our SAGs and our transverses and measurements, just showing that we have perfusion, what we call the tree of life. Okay, so the other thing we could do, is we could do power Doppler. And you'll see how much more information you can get with power Doppler. So whereas we weren't able to get much information in that superior, now we can really see all these arcuates filling in, much more clean in the superior. The only disadvantage to this, and it's not nice to see all of this, is that I can't see my red and blue to determine who's artery or vein. So I might be kind of hitting the wrong stuff as I go through simply because I don't know who's who. So it's up to you. Power Doppler is nice, especially for those arcuates. And I like color Doppler when I'm doing the segmentals and the interlobars, simply because I can determine who's artery and vein a little bit quicker. And you guys have all done this on the ovaries, and you're like, it's a vein, it's a vein, it's a vein, it's a vein. So you're not playing that game quite so much. Okay, let's go. And once you bring up, on this machine, once you bring up power, then you have the option down here just to switch between the two. All right, let's bring our velocity up just a hair. Big breath in. And so we'll start with gain up. So we're going to start with this inferior. I'm going to show you guys how we kind of angle correct. So here we go. So go ahead and brace. We're going to do SAG. We're going to do inferior. We're going to start with a segmental, and we're going to do segmental 1. Now keep in mind, we're going to do 3 of these. Today we're not. We're just going to kind of see what we're going to do. But we are SAG, inferior, segmental, our first one. We're going to get that resistive index. Then I would do my second one, my third one. Then I would move into the interlobars. You could choose to do all of your segmentals from superior, mid to inferior first, and then do all your interlobars, superior, mid to inferior after that. But I find when I'm having these kidneys and I can get that superior towards myself and I'm kind of optimized at superior, it's easier just to do all of my Dopplers in the superior than having to go superior to mid to inferior, then back to superior, mid, and inferior. So I just do everything on the superior, everything on the mid, everything on the inferior, but it's entirely up to you. All right, so we've got this inferior portion. We've got some nice segmentals coming in, kind of right in here. So I'm going to put my pulse wave on, and my pulse wave's like, hey, this is what you want to sample, right? And I'm like, no, that is not what I want to sample. So we're going to hit our update button, and we're going to bring this up, and I want an angle. See how and you can breathe if you need to. So I'm going to click my angle button and see how it brings this up. And when you're ready, go ahead and breathe over, because then I want to hold it for just a second. So we want to make sure when we're putting this in here that our angle is absolutely parallel. So I can add maybe a little bit of angle to this to really get that guy in the center of that vessel. Update again. Very tall waveform, so I'm going to increase my scale. Go ahead and breathe. And there's my waveform. So we had to adjust our angle just slightly to get in the center of that segmental flow. That put us at 49 degrees. Good, bad?
Good.
Yay, good. Okay, and then the next thing, some of the machines we're actually going to have to push. I want to do a resistive index. With this machine, we just add a caliper. So add caliper. I'm going to find a waveform that looks nice and clean. So like this guy, maybe not as clean. This guy's looking like he's kind of flattened out a little bit. So we're going to find somebody who looks pretty much appropriate for everybody else. So our peak systole to our end diastole, and it puts our resistive index at 0.6. So are we surviving?
Uh-huh.
We are, congratulations. All right, so then we would repeat this again. So the inferior, we repeat segmental 1, segmental 2, segmental 3. And now we're just,
use the same vessel?
Same.
1, 2, 3, we can do it with
You can do the same vessel. Yep, you got it. Yep, if you can find it, you're in yes, you got it. And in this case, we're gonna go to do our interlobars. Interlobar 1, and again, I would have 2 and 3 subsequently. All right, when you can't think of it. So here we are in that inferior again. We're going to throw our color on. Now, these interlobars are going to be the ones that are extending from the pelvis into the cortex. So I'm going to kind of eyeball that guy right there. Maybe a little bit more angle, just to make him parallel with the vessel. Back him up just a little bit. We kind of like this guy, not the appropriate one, right? Because he's kind of, we gotta have some problems. So either of these guys, maybe we'll start with our first guy. So add caliper, peak systole, and diastole. 0.68. Oh, you're getting close, sister. Oh no, we're fine. It's totally fine. Then we've got our resistive index is 0.68. So after that, who's next? Arcuates. Button. Do my job here. All right, big breath in and hold it. All right, now if we have problems finding these, they're so tiny, we can just go to our power Doppler. You can see that there's a lot more to go. And we'll just grab one of these guys. I think we want our angle. Go ahead and breathe if you need to. We're going to get our angle a little bit different here. And when you're ready, big breath in and hold it. Let's try to get one of these angled towards our transducer, all the way out here. All right, so peak systole, I like this guy. He's nice and kind of filled in looking. And diastole, and our resistive index then is 0.48. Any questions?
Can you explain again what was 1, 2, 3?
Oh, so see how I'm doing arcuate 1? I would do then another, I would repeat all this, arcuate 2, repeat all this, arcuate 3. You could use the same vessel or different vessels, but we're going to take 3 assessments.
Okay. So that's kind of the same as if we're doing the crown rumblings.
Yep, so I did 3 segmental crown rumblings, 3 interlobar crown rumblings, 3 arcuates, and then you do that for the inferior, the mid, and the superior. So you're going 369, 369, 369. So every section has nine spectral waveforms. So here's Shea's excellent cheater method. So say, go ahead, big breath in. So say I have a pelvic kidney, and so it's really easy to manipulate whether I can have the superior towards me or the inferior towards me. So the nice part of this is, here, if I can get these to point straight towards my transducer, so say I get one, so say I get one of these vessels and it's pointed straight, so see how this guy is pointed straight toward, that's really not good, go ahead and breathe. Sorry, that was me. Sliding off my patient here. So if I can get one of these, go ahead and big breath in again, to point straight towards my transducer, then I don't have to do angle correct. Let's see if we can find one. So here's one pointing straight towards my transducer. So in that case, I don't have to do angle correct. So you can kind of cheat a little bit if you can get it straight up. And that's why, go ahead and breathe. And that's why these pelvic kidneys are so nice, because you can get the superior. So I could scan from here and get that superior towards myself, or I could scan from here and get that inferior towards myself, whereas we're not fighting the ribs. So these transplant ones are a little bit easier because you can get them to just point straight towards you and you don't have to worry about angle correcting, or at least minimally angle correcting. I think we had one yesterday that was like at 4 degrees. So we were just barely having to angle correct.
And is that how you know, it's the degree measurement is how you know that it's pointing basically straight toward the transducer, or?
Yeah, and visually.
Okay.
So no, if I take this off, so it's going to be visually. Let me, let's go back live here real quick. Okay, go ahead and big breath in. Okay, so if we look at this kidney, let's get some, so we can find out what's missing here. Go ahead and breathe. So see how this is pointed straight up?
Yes.
So I know it's going to be straight at my transducer.
Oh, okay.
Whereas
90 degrees.
Say this guy,
Okay.
he's not, or even this guy's not pointed towards my transducer.
Yes.
So it's the one that's pointing straight towards my transducer, I can get away with not having an angle for.
Okay.
Making sense? How do you guys feel about that business? We feel so cool. Okay, I'm going to leave you gooped up. That's okay. All right, so again, that GE is going to be a little bit harder to do the color on. And the S2000, so number 3 and number 6, will stay updated while you're moving your spectral Doppler around. These machines, you want to make sure you're updating to see exactly where that spectral Doppler is ending up. So you need to be live to place your gate, and then you can ask it to read the waveform. Whereas 3 and 6, it's always live, so you can see where exactly when you're moving your gate, what's happening. It's getting that continuous spectral read. This one's like either reading or placing the gate, whereas those ones are at the same time reading and placing the gate. I see the confused look in your eye.
Yeah.
We'll get there. We'll get there. All right, I'm going to leave you gooped up.